Dr. Schechter, how are you doing?
Hi,
Nice.
Thomas. How are you?
Doing quite well. Super excited to have you here. And thank you for making the time in your super busy schedule. And thank you, everyone, for joining us tonight in our Instagram Live, or good morning, depending on where people are watching from. But so tonight's discussion is going to be on debunking myths in gender affirming surgery. And there are a lot of myths that are out there, unfortunately, that have developed over the past couple of years. And I want to have this conversation with Dr. Schechter to really explore them and find ways that we can, just change that for the sake of our patients. So just a brief introduction, myself, Dr. Satterwhite, plastic surgeon based in San Francisco, perform gender affirming surgery. Dr. Lawrence Schechter, it'll take me half an hour to go through his entire resume, but he's a professor of surgery. He runs a gender program at Rush University, heavily involved in research. If there's any landmark paper in gender affirming surgery, his name is on it. Outside of his academic and clinical pursuits, he is heavily involved in every organization out there. So he's in the board of directors of WPATH. He's now president-elect. Woohoo! So in 2 years, you will be the formal president of WPATH, but involved in developing the standards of care for WPATH and for the care of our patients, on top of the numerous other organizations that you're in. So the American Society of Reconstructive Microsurgery, ASPS, the American Society of Plastic Surgeons, Gender Society, oh my gosh, there are 10 others. There's so many things. And then you're also an advocate. So you're involved in expert testimonies in several high profile cases throughout the country. And everyone throughout this world and universe knows who Dr. Schechter is. One quick thing, housekeeping thing that I wanted to say just for the audience. We do have the comments turned off, but to avoid any potentially harmful commentary. But if you have any questions throughout this discussion, just ask those questions through the question function, and then I will look through those and point them out. So, the one thing that I know, I just wanted to start off, Dr. Schechter, you do so much, you're tireless, but what drives you?
Well, first of all, Thomas, first of all, call me Lauren, please. But Thomas, it's a pleasure to be here, and I appreciate the opportunity. And let me thank you for your role and your service as program chair, scientific chair for the most recent WPATH meeting in Lisbon. It was a wonderful meeting. Dr. Satterwhite, Dr. Mujde-Ozer were our two program chairs, and it was the largest meeting that we've had to date. So thank you very much. And what drives me? That's a great question. Let me thank our team at Rush. Without all the help from everyone, I really wouldn't be able to do the work and care for our patients. So, I've been performing surgery and been involved in the field for a number of years, and it's near and dear to my heart. I feel very passionate about the work, both as a physician, but also helping people and trying to help advance the field. And early on, I think as we all recognize, there were many challenges. Access to care was limited. Insurance companies didn't cover it. Hospitals were reluctant to allow people to perform surgery, and we've come a long way. We have some challenges. We'll talk about those challenges tonight, but we've really come quite a way. And so, those are the things that really drive me and keep me going.
Yeah. And so, just speaking about like the things that are happening recently and throughout the entire, I think lifespan of gender surgery, and gender affirming surgery has been around for a long time, for decades. And it's just recently that it's getting now more into the public, arena. What I want to understand and maybe, just get some insight is, why is gender affirming care of minors being brought so much into the public and so much in a very negative light? Why is that?
Yes. So, you raised a good point, and I think it's important for people to recognize. We hear many criticisms and critiques of the field. In the modern era, gender affirming surgery has been around, different names, different terms, for almost 100 years. And so it's not new. The benefits of surgery have been reported by surgeons and healthcare professionals for decades across the globe. And so some of the questions or challenges that we face, especially when we're talking about young people, there has been an increase in the number of young people who seek medical and surgical interventions. And the ratio, the number of people assigned female at birth has increased. Historically, early on, majority of people we saw were assigned male at birth. Probably 10, 12 years ago, maybe a little bit more, we began to see more people assigned female at birth, and many of those procedures are represented by gender-affirming chest surgery, chest masculinizing surgery. We've recognized the heterogeneity of gender, the diversity of gender. We see more people who identify as non-binary or gender diverse. And, I think those are part of the reasons that people have begun to, raise issues around affirming care for minors. And for people who are unfamiliar with the field, I think education is extremely important. And when you sit and you talk with people and you meet with people and you meet with with families and you hear their stories, I think you really begin to understand what it is we do and how we're helping people.
Yeah, that totally makes sense. And so, what is it that we can do to depoliticize gender affirming care, and particular gender affirming care for minors? Is there any hope?
Well, I think there's hope. And as we started the talk, we've really come a long way in the last couple of decades. If you just look at the history, when I started, insurance companies didn't cover care. Now, the overwhelming majority of our patients are covered by insurance. When I started, many people had to leave the country to access this medically necessary care. Now, that's really no longer the case. You see diversity programs, human rights campaign, expanded insurance coverage, a larger number of hospitals, training programs, academic programs have started not only surgical programs but comprehensive programs in gender health and LGBTQ plus care. So I think it's about evidence, it's about education. Part of our role, part of our responsibility is to add to the evidence, add to the scientific data. What do we need? We need more studies. We need larger studies, larger patient samples, longitudinal data, continue to build on the strong basis that we already have.
Yeah, and that's a very good point. So, just touching upon research, so I think we all do, acknowledge that we do need more research. But do you feel that gender affirming care is held to a different standard when it comes to, quote unquote, high quality research compared to, other surgical fields? And, I know you wrote, a recent paper, which was wonderful, showing that the level of evidence for gender affirming care in research is on par, if not better, than in other fields or in other papers of plastic surgery or urology, right? But why is it a different standard for gender affirming care?
Yeah, and I think that's an important point that you raised, Thomas. The term level of evidence has sort of been weaponized in the area of gender affirming care, and it's applied disproportionately in our field. For the viewers, levels of evidence, it's a term that refers to study design. And so when we talk about level of evidence, we're really talking about the type of study or the study design. Levels of evidence graded 1 to 5. Most of the evidence we have is level 3, 4, and 5. And so level 3, 4, 5 evidence doesn't mean poor. It means level 3, 4, 5 evidence. And that's the reality for surgery and clinical medicine in many areas. We have obvious limitations to what are considered higher levels of evidence, level 1 studies, randomized controlled studies. It goes without saying that in surgery, some of the criteria for higher levels of evidence, things like blinding people, blinding study participants. Obviously, if we've operated on a body part, people aren't blinded. There's no placebo in surgery. We feel it's unethical to randomize people away from medically necessary surgery or compel or coerce people to participate in research studies in order to access medically necessary care. So levels of evidence in gender-affirming surgery are similar to many other areas of surgery, but this is an argument that's somehow being used to call into question what we do. And it's really applied disproportionately in this field.
Yeah, thank you. And I mean, are there studies that show that gender affirming care is harmful?
Well, so what we know gender affirming surgery in appropriately identified people is safe, it's effective. We consider it medically necessary. The benefits include improvements in overall health and well-being, reduced negative health outcomes, reduction, alleviation of gender dysphoria. We're often asked to produce these mountains and mountains of evidence. And I'm not here to speak against the importance of the medical literature. That's important, and that's one component of our decision-making process. But so is our clinical experience, so is the experience of our patients, so are our patients' values and preferences. And just like any area of medicine, that's how we use the best available evidence. We speak with our patients. We engage in a shared decision-making process to arrive at a treatment plan that is most appropriate for that individual person.
Yeah, and that completely makes sense. And what's also interesting is that for young people, gender affirming care is even provided to cisgender, um, you know, kids and adolescents. And I think folks don't understand that. So the use of hormones, gynecomastia surgery, or operating on, young girls who might have, gigantomastia, right? So that's also been done all the time on our young patients, but is not addressed, and that's held to a completely different standard than the types of operations that are performed on transgender and gender diverse kids, right?
Well, we know, Thomas, you and I know that plastic surgeons perform breast reduction in cisgender young women under the age of 18,
Mm,
rhinoplasty under the age of 18, gynecomastia surgery. And these are all helpful procedures, again, in appropriately identified people. And so to suggest that similar or analogous procedures are not helpful in appropriately identified young adolescents with gender dysphoria, I don't think is fair. I don't think it's equitable, and I don't think it's accurate. Now, we also know, to be fair, right, that not all individuals undergo
mm,
surgery. And
mm.
so I think one of the misconceptions is that we're talking people into surgery, we're trying to coerce people into surgery, that an individual who experiences gender incongruence or gender dysphoria somehow is automatically set down a path of medical and surgical interventions. And as we both well know, that's simply not the case. We work with colleagues in other disciplines in a multidisciplinary way, whether it's colleagues in primary care or endocrinology or behavioral health or mental health. And so, you referenced breast reduction in cisgender adolescent girls, gynecomastia in young cisgender boys. None of these people undergo the same rigorous processes for individuals contemplating, for example, masculinizing chest surgery.
Yeah. That's a very good point, right? And the way that I view it is for all of our patients, it's like someone who's going through an organ transplantation, right? That's that degree of interdisciplinary evaluation that our patients have. So people from multiple areas of medicine who are taking care and evaluating our patients. So we're not out there just pulling people into the office doing these operations and just shooting from the hip. And I think it goes to your point, Warren. It's about education. I think everyone needs to understand just a high level of rigor that is involved in taking care of patients. I think the one thing that's also brought up, just switching gears slightly, the other concern that is brought up is that, well, young people, their brains are developed and they're going to have regret, right? And so we should be operating now. So what do you say? I know, because I have people ask that all the time. So what do you say to that?
Yeah, and that's a good point. And I think we as professionals and healthcare professionals and surgeons, have to understand. And when people have those questions, regret, and we can talk a little bit about regret. It's a bit of a nebulous concept, but we'll talk about it. I think we have to acknowledge that too. And so one of the things that we engage in as part of the consent process and part of the consultation is that sort of future thinking or forward thinking. What ifs? What if your needs change? Have you thought about that, right? And have you given consideration to the possibility that things may change in the future? We talk about regret, and that's an interesting term because, it's really not well defined. And again, it's used as it's weaponized in this field.
Mm,
If we look at regret regarding medical decision making, in the area of gender affirming care, it's lower than in many other areas. And I attribute that largely to the extensive process that we take in people considering surgery, that multidisciplinary process, that discussion with primary care, behavioral health, mental health, surgery, really the preparation, not to mention the fact that people have typically thought about the procedures for a long time. Waiting lists are long, so it's not as if they see a Thomas today and they're in the operating room in a week. So it's a process, and it's a lengthy process for many people. And again, we attribute our low rates of regret, meaning I would have done something different, to this process. Now, we also know, though, that we have to manage expectations, right? We know that the world doesn't change when someone has surgery, and the world can be a difficult place. People face ongoing discrimination,
mm,
ongoing stigmatization, and preparing people for that resilience, to understand that the world is, can still be a difficult place, especially for gender diverse people. That's part of what we're here to help people with.
yeah. And so then do you think that, young folks have the ability to make appropriate decisions for
I think,
themselves? That's a question
yeah,
often brought up to me.
I think that's a case by case basis, right? And there are things that we look at. There are things that we look at in conjunction with their other healthcare professionals, their team of professionals, their primary care professionals, their behavioral health and mental health
Yep.
professionals. And so that's a case by case basis. There will be some young people who do have the ability to engage in future thinking, to understand the process. There'll be others who need more time. And that's not necessarily, or age isn't the only
Mm-hmm.
factor, you know, with that. And so, of course, we operate as plastic surgeons on people under the age of 18 for a range of conditions. Now,
Sure.
we also obviously engage the parents and caregivers. So for people under the age of 18, there's the parallel process of assent, their ability to understand the risks, the benefits, the options, but it's also the parents who engage in that informed consent process and provide consent from the legal perspective before proceeding with surgery.
That's true. And there was at the WPATH conference, there was a wonderful presentation. I forgot who gave it, but talking about the idea of risk, where we allow people and young people to pursue risky things and don't really bat an eye about it. So, such as sports, for example, right, or driving, right, but we don't allow them to self-explore, and take risks when it comes to their gender, perhaps. And it just makes me wonder, what is it about gender that people have hangups about? I mean, what is it that's making people have this kind of double standard in terms of how they view it?
Well, I think we look at it in sort of in different levels. So, before we engage in surgery, an irreversible process, we want to ensure that people have gone through a very thorough process of self-reflection,
Yes.
that, as we've discussed, they've had the maturity, they have the insight, they have the ability to assent, their parents are in agreement. And so, I think it's that process, or the what I like to say, the integrity of that process, um, that I think is really critical for people contemplating, young people contemplating surgery. I think as far as exploring socially, sexually, those are certainly things that adolescents and young people and adults will do.
Yeah. And so, can you add? I think the regret and detransitioning oftentimes get intertwined, but they're separate things, right? Could you tell me the differences in the audiences between regret and detransitioning?
Yeah, so again, it's interesting. We don't use this term regret in other areas of plastic surgery. So I would ask you, Thomas, how many times in your career have you removed breast implants in a cisgender woman? And did you ever call it regret? Did you ever term it that?
No,
No.
no, it's just time for change.
Time for a change, right? Regardless of why they were placed, for reconstructive purposes, for aesthetic purposes, many times someone's 70 years old and they say, I'm done, right? Just take them out. And we never call that regret. And so it is this sort of double standard, or disproportion, or difference in the use of terminology. And one of the things that I would like to do is start applying that term regret to all of these procedures in plastic surgery. So if we look at regret, right, the regret of I'm wrong, I'm not who I believe myself to be, that's low, right? That's low. Can people have regret around a procedure? Of course, and that occurs in every surgical procedure, every medical intervention.
Mm-hmm.
But remember, regret is bidirectional. And I would say early in my career, more people regretted not having access to care because of all the barriers, whether lack of insurance coverage, et cetera, or limited number of surgeons. And so people lacked access and regretted not having access to this important and medically necessary care. Now, the term detransition, for example. And so someone may, for instance, stop taking hormones. And they may do that for any number of reasons. Sometimes there's a medical reason for it. Sometimes they feel they're no longer needed. And those are individual reasons. If we talk, or we, look at requests for surgical reversal, while they're not common, I think it's incumbent on us to, speak with patients, understand what the basis of that, of that request is. We have to care compassionately for people. We have to listen to them, and if possible, help them.
Yeah. So the theme that I'm getting here, everyone, I wish everyone could understand, is that we listen to our patients, we take them on a case by case basis, and we work with them, right? Where there's no coercion, and there's no, I mean, we're human beings, and we're providing, I think, all of us, patients, doctors, and we're just working together to provide the best care for the people that we're working with. I just had, and speaking of someone question when we were talking about permanent. So someone was asking about like facial implants. Some of them just briefly can be permanent, meaning that we do leave them in, but they can be taken out. Once again, if you do have issues with those implants, or once again, you do have just a change in how you feel about your face, just like with breast implants or other aspects of surgery. One other person who's listening was asking about intersex. And are there, specific precautions we need to be mindful of, or what is our approach with intersex um, patients? Could you comment on that, Lauren?
And so, the care for people intersex or variations in sex traits, is also evolving and has changed. Generally now, I would say the trends for children, for adolescents are ensuring the ability to urinate, to defecate, to preserve reproductive capacity if possible, but generally to defer um, interventions such as vaginoplasty or certainly phalloplasty until the patients are older, until the people are older and they can engage, in that informed consent discussion, assent to care, articulate their preferences. So early on, it's focused on, bodily functions, preservation of reproduction, and then as people get older, there may be interventions to align their body in terms of anatomically with their identity.
Yeah, that totally makes sense. And so I think we're down to 2 minutes. So I think one question I wanted to ask you is, what do you think, what is it that we can do as surgeons and other medical providers can do um, amidst all the pushback that's going on, really help support our patients? I mean, there have been some times, and maybe you as well, where you've come across folks who might be in training, and they're like, "Oh my gosh, I'm nervous about going into the profession of gender affirming care because of some of the the pushback, and maybe even some of like the violence or potential violence." Like, but what can we do to keep fighting for our patients?
Yeah, I think that's a great point, Thomas. I know we're short on time, but one thing I would say is, we want to engage in ongoing research, ongoing academic study. And the current environment makes that difficult. Why is that difficult? People may ask, well, do you have a registry? I can tell you in speaking to patients, people are afraid, right? They don't want their names put on lists when you have government entities requesting private health information from universities and from hospitals. People are very understandably scared and reluctant, to participate in registries and longitudinal data. So it really creates this chilling effect on our ability to get more data. People are simply scared. I think for the trainees, people who are interested in it, I think it's a wonderful time in the sense that there's infinitely more opportunities to learn than there were a couple of decades ago, and so you can avail yourself of any number of surgeons who would be willing and more than interested to allow you to observe. Educational opportunities have expanded dramatically, whether through WPATH or other educational offerings. And so I really think there's a lot of robust and high quality educational opportunities out there.
Yeah, and that totally makes sense. It really is about, education. So we are at the half hour mark. This went by so quickly. I could have you forever, but I wanted to thank you, Dr. Schechter, for spending this evening with us and just providing this wealth of knowledge to me, to everyone who is listening. We did record this, so we'll have it posted by next Monday, so other folks who weren't able to attend can view it. If you want more information, you can go to our website, alignsurgical.com, or Instagram, alignsurgical, or go to wpath.org for additional information as well. But once again, Thank you so much, Dr. Schechter or Lauren. But
Dr. Satterwhite or Thomas, thank you so much. I really enjoyed it. It was a pleasure.
yes, till next time, take care.